to the group, please press *6 on your phone to unmute and to mute. If you are using your laptop for audio and visual during the meeting, you can control the mute function on the Hangout at the bottom of the Hangout. For the UR board member, please reserve the question until the end of the presentation or may ask in the Google Hangout meeting chat. For public comment, if you would like to provide a public comment, a conflict of interest must be on file. Please send an email to medicaidpharmacies@utah.gov. Attendees that are not members of the DUR board, please enter your contact information on the Google Meet chat or email medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after meeting to help us improve our process moving forward. Thank you very much. And look like we have a quorum today. I will let Dr. Smith. Thank you.
Thank you. All right, I guess the next item is review and approval of minutes. Has everybody had a chance to review the minutes? Are there any changes? Okay. Yes, you have your hand up. Kumar, you have to unmute yourself.
I propose we accept the minutes as drafted.
Oh, thank you. Is there a second?
I'll second that.
Great. All in favor of approving the minutes, say aye.
Aye.
Aye. Aye. Any opposed? Okay, the minutes stand approved. Thank you for that. And the next item on the agenda, Brian Larson with the P&T committee update.
Good morning. So in February, we reviewed CGM, continuous glucose monitoring, and those will be added to the preferred drug list effective April 1st. So today's discussion is a continuation of what we started there. In May, we'll be discussing glucagon products, and we'll also have our annual report from the ACOs.
Sounds good. Thank you so much. That's a great segue into our first agenda item, continuous glucose monitoring. And I believe we have the University of Utah DRRC presenting. Is that correct?
Yes. Let me get my slides up for you here.
Yep.
Tell me when those come through for you to view.
Yep, we can see them.
Okay. Okay. So today we are reviewing continuous glucose monitoring devices and their place in therapy, specifically the personal use CGM devices. In this presentation, I'll be referring to two types of CGM systems: the real-time CGM, abbreviated RT-CGM, and intermittently scanned CGM, abbreviated IS-CGM. Both groups of devices continuously measure glucose levels. The RT-CGM systems also continuously display glucose levels to the user in real time and have real-time alarms. With IS-CGM, although glucose is continuously measured, the levels are not continuously displayed in real time. Levels display on the receiver only after the user has manually scanned the sensor on their arm with the receiver. However, there is a real-time alarm feature incorporated into the newer Freestyle Libre 2 IS-CGM device. With a real-time alarm, patients are alerted to problematic high or low levels that otherwise may have gone unrecognized without the alarm. I will also refer to SMBG, which stands for self-monitoring of blood glucose by fingerstick testing. CGM is approved for the management of diabetes. Most personal use devices are approved for using the sensor measured glucose readings to base treatment decisions. In other words, these devices can be used to replace most blood glucose testing by fingerstick in order to make therapy adjustments. The exception is the Guardian Connect system, which is labeled for use as an adjunct to SMBG. Problematic glucose readings and alerts from this device indicate when to perform a fingerstick test to confirm the CGM measurement. The FDA approved age for use of each device differs between products. Each is approved for adults, and we have 3 approved for pediatric patients. Table 1 of the report on page 8 summarizes additional key features that differentiate products. Eversense is the single device where the sensor is fully implanted under the skin by the healthcare professional in a clinic procedure, whereas the other devices, the sensor is transcutaneously placed by the user. The site of application for the CGM sensors and the frequency at which they must be replaced differ between each device. 2 devices, Guardian Connect and Eversense, require twice daily calibration by fingerstick testing to ensure accurate readings, whereas others do not require manual calibration. Guardian Connect and Eversense also require the user to own a compatible smart device, such as a smartphone, that serves as the receiver for displaying glucose information to the patient. Dexcom G6 and Guardian Sensor 3 that's used in Guardian Connect are also compatible with certain insulin pumps. So even though these devices are intended to replace fingerstick testing for therapy decision-making, they do not entirely eliminate the need to do that occasionally. Self-monitoring is required during the use of any CGM device when symptoms do not correspond to the censored measured glucose reading. During the warm-up or initialization phase of a newly placed sensor, or when glucose levels or the rate of change arrow are not displayed. User manuals for these devices point out certain populations for which the accuracy of the device is undetermined, such as during pregnancy, dialysis, or with use of other implanted devices like pacemakers. Guardian Connect is contraindicated in patients unwilling or unable to meet the minimum manual calibration of twice daily fingerstick testing. It is important for the prescriber to educate the patient about which agents, especially over-the-counter products, that can interfere with their specific device, and what steps to take in the event that the patient has temporary doses of interfering agents. Compared to dispersed SMBG data, the granularity of CGM data can allow better tailoring of insulin dosing, since glucose trends and excursions can be seen more fully relative to medication dosing, the time of day, or other patient-specific factors that can affect blood glucose fluctuations. CGM is also useful for revealing unrecognized or non-symptomatic hypoglycemic and hyperglycemic events. Not only are patients alerted to problematic levels in real time, most devices also have an alert for when the algorithm predicts an approaching hyper or hypoglycemic event based on the patient's glucose trends. Patients can then proactively address their glycemic needs and prevent highs and lows altogether. These real-time alerts can also help relieve fears of hypoglycemia or nocturnal hypoglycemia, such that patients may be more willing to tightly manage their glucose. Barriers to CGM therapy may include the provider not having enough time or resources to provide training and support for the proper use of a device. On the patient's end, they or their caregiver must be able to understand all the features of the device, directions for use, and how to interpret and respond to CGM data and alerts. Alert fatigue and skin reactions to adhesives may become a barrier during the use of these devices. Altogether, guidelines cite numerous studies in children and adults with type 1 diabetes on intensive insulin therapy that showed improvement in glycemic outcomes, such as reduced A1C in previously uncontrolled patients and reduced episodes and time spent in hypoglycemia with CGM versus SMBG. In type 2 diabetes, significant reductions in A1C have been demonstrated with personal use CGM in those on intensive insulin therapy. So the ADA guideline has recommended CGM for patients on intensive insulin therapy supported by A and B level evidence respective to RT CGM and IS CGM. For patients who are not on intensive insulin, there are limited low-quality studies suggesting benefits with CGM over SMBG. So while the ADA has described that CGM may be considered for these patients, this suggestion is based on low-quality studies. In 2020, in the 2028 ACE and ACE guideline, authors briefly mention personal use CGM and state that it may be considered for patients on intensive insulin, patients with history of hypoglycemia unawareness, or with recurrent hypoglycemia. And they cite their 2016 guideline that more thoroughly addressed CGM technology. However, in that 2016 guideline, the recommendation for use of CGM was reserved to patients with type 1 diabetes since studies in type 2 were limited at that time. And finally, in the 2017 International Consensus Guidelines for the use of CGM, the authors recommended this technology for all patients with type 1 diabetes and patients with type 2 diabetes on intensive insulin who are not meeting glycemic targets. Guidelines also include consideration for CGM use during pregnancy to achieve glycemic goals and to address hypoglycemia issues, but it should be used as an adjunct to SMBG in this population. For pediatric patients, the ADA recommends consideration for CGM in all children and adolescents with type 1 to help improve glycemic control and to ensure safety during various activities. Patients who are selected to receive a CGM device should wear the device on a near daily basis for maximal benefits as recommended by guidelines. With the IS CGM devices, the sensor should be scanned at least every 8 hours with the receiver. CGM summary metrics and the generated ambulatory glucose profile graph that are used for assessing whether the patient is meeting time and range goals are reliable if at least 70% of possible readings are captured over the previous 14 days. As part of CGM prescribing, patients should have robust diabetes education, training on the use of their device, and ongoing clinical and technical support. This includes regular follow-up with the provider for assessment of their data and their medication regimen, and also to encourage adherence. As previously mentioned, CGM users should have the ability to perform self-monitoring as needed for the proper use of their device. Considerations for PA criteria were provided on page 24 of the report. In brief, these included requiring a diabetes-related diagnosis. You may consider reserving CGM for patients on intensive insulin therapy, since that is where there is high-level evidence of benefit over SMBG. Evidence is limited for patients on non-intensive insulin regimens, such as basal-only insulin, but perhaps some patients in that subgroup could be considered on a case-by-case basis. The patient may be required to meet the FDA-approved age for use of the device. And for the devices that must be manually calibrated, such as Eversense and Guardian Connect, you may require documentation that the patient has been compliant with SMBG at least 2 to 3 times per day over the last couple months to demonstrate their commitment to meet the daily requirements for those devices that require calibration. So that's all I have today for you. Do you have any questions?
Thank you, Valerie.
Mm-hmm.
Any questions from the committee?
Valerie, I don't have any questions here, but I just want to say thank you to you and the DRRC team for putting together such a thorough report
Oh, yeah.
and this great presentation. Very well done. Thank you.
I appreciate the compliment. Thank you.
You're welcome.
Okay, so if we don't have any questions, should we do public comment next or start the prior authorization discussion?
I think the next is the public comment. We have 3 public comments.
Okay. Just a friendly reminder to mute your line if you're not speaking. Okay, so the public comment. Do we have Roy Thomas from Dexcom?
Yes, I'm here.
Go ahead.
Thank you for the opportunity to provide testimony today. Today, we're requesting that the Dexcom G6 be added to the PDL and covered for type 1 and type 2 patients on intensive insulin without additional coverage criteria. The 2021 ADA Standards of Care recommends real-time CGM for patients using multiple daily injections or pumps, regardless of diabetes type, due to the risks of the treatment regimen. They state, when used properly, real-time CGM in conjunction with MDI or pump and other forms of insulin therapy are a useful tool to lower and or maintain A1C levels and or reduce hypoglycemia in adults and youths with diabetes. In addition, they also recommend that a patient not have to step through the use of finger sticks prior to starting CGM. They state access to CGM devices should be considered from the outset of the diagnosis of diabetes that requires insulin management. This allows for the close tracking of glucose levels with adjustments of insulin dosing and lifestyle modifications, and removes the burden of frequent SMBG monitoring. Severe hypoglycemia is a barrier to glycemic control, as most patients express the fear of future hypoglycemia by reducing their insulin. The fear of hypoglycemia is recognized in the medical literature and can result in decreased motivation and poor adherence to intensive insulin regimens in both type 1 and type 2 patients. Impaired awareness of hypoglycemia is another challenge these patients face, and that is when they lose the ability to perceive the onset of hypoglycemia, and that's associated with a 9 to 17 times higher incidence of severe hypoglycemia. A real-world study looked at real-time CGM initiators within 1 year of a type 1 diabetes diagnosis and found that CGM users had significantly greater improvement in glycemic control and lower numbers of emergency room diabetes-related ER visits than non-CGM users. So just to conclude, based on the strong evidence and guidelines from the ADA, we ask that patients with type 1 and type 2 diabetes treated on intensive insulin to be able to access CGM without additional coverage criteria requirements, such as the use of SMBG. Many providers would prefer to start their patients on CGM as soon as possible to prevent adverse events such as hypoglycemia or DKA, and also so they don't learn bad habits with regards to diet, lifestyle, and treatment by using finger sticks. In addition, there is no evidence demonstrating SMBG's value as a predictor of successful CGM use. Starting CGM when starting intensive insulin allows patients to use their insulin safely and effectively to make treatment decisions and be successful with regards to the management of their diabetes. Thank you.
Thank you. Any questions from the committee?
Dr. Smith, I have one. This is Joe from.
Yep.
It's mentioned that you mentioned in their review that the G6 is not recommended or not advised for pregnant patients. Can you expand on that, Roy? Is that because the studies have not been done, or have you done the studies? Has Dexcom done the studies and you're not confident with the measurement ability in those patients?
Is that a question for me, for Dexcom, or?
Yes.
Yes.
Yes. So currently, the we're not labeled to be approved to be used in patients with who are pregnant or with gestational diabetes, according to the FDA label. But there are studies that show the value of CGM in pregnant patients with regards to neonatal outcomes or with improvement in neonatal outcomes. So we are working to try to have this label expansion with the FDA, but many providers are certainly having success using CGM in patients who are pregnant and have gestational diabetes. And there are other states that do cover for that population, regardless of the label.
Okay, so just for clarity, Roy, it's not that the studies have been done and they were, didn't show accuracy or whatever. You simply don't have the data yet, as I understand what you're saying.
Yeah, so in Europe, we're actually indicated to be used in women who are pregnant. So there is accuracy data. They're allowed to use it in Europe according to the label. And we're in the process of working with the FDA to have that in the US label as well. So studies have been completed, and efficacy and good outcomes have been demonstrated as well.
Thank you.
I have a question. You mentioned something about the use of the device in preventing bad habits and something about facilitating lifestyle change. Could you say something about what we know about that, or what data we have in regard to lifestyle?
Yeah, so CGM does help patients make good diabetes treatment decisions. So they're able to eat better, they're able to engage in activities that they normally would not engage in because maybe they have a fear of hypoglycemia, such as during exercising. So it does allow the patient to really not just use their treatment effectively, but make decisions that benefit their overall their overall management of diabetes. We do have some studies with type 2 non-intensive patients showing that patients were able to actually decrease their medications. They were able to make good decisions with the CGM because of the information from the CGM.
Thank you.
Hi, hey, this is Eric Cannon. A quick question. So you were in your kind of prepared remarks, you said a lot of physicians would rather move patients directly onto a CGM at the time of diagnosis versus starting with self-monitoring. Yet, help me understand, because self-monitoring is still required in the 2-hour warm-up phase with the G6 at the point in time that you change the sensor. You change the sensor every 10 days. There are going to be times when, for whatever reason, they may not be getting a response off of the CGM, and so self-monitoring is again required. So I understand that comment that they would like to do this, but self-monitoring is a factor of having type 1 diabetes to some degree, and even, brittle type 2. So can you clarify that? I mean, are you saying that your CGM, the G6, just completely replaces self-monitoring?
Yeah, so the FDA has approved the G6 as a replacement for finger sticks for patients 2 years and older. You're correct. During the 2-hour warm-up, the patient does not have CGM readings to make decisions with regard to their treatment, any diet decisions or lifestyle decisions. So they would need a finger stick, a glucometer during that 2-hour warm-up. So the ADA actually recommends that patients on intensive insulin test with finger sticks 6 to 10 times per day. Many patients are not even coming close to that 6 to 10 times testing requirement by the ADA. And also, too, testing at night when most hypoglycemia occurs. 55% of nocturnal hypoglycemia and severe hypoglycemia occurs at night is almost impossible. So even if a patient tests 6 to 10 times. They're only testing during the day. They're not safe at night when they use their insulin. So what ends up happening is many patients give themselves less insulin at night in their evening hours. They eat something. I've heard stories, and many providers, I'm sure, have heard where the patient eats some cake or has something because they don't want to have a low at night. They have a tremendous fear of hypoglycemia, and essentially they have uncontrolled diabetes as a result. So SMBG, yes, during the 2-hour warm-up time period will be needed. During those instances that Valerie had, where if the glucose reading, if the symptoms don't match the readings on the CGM, you can use the SMBG to back you up. But the primary decision making is made off of the CGM as according to the label.
Okay, I mean, I'm not discounting the fact that there are benefits of the CGM, and clearly, you know, I understand the multiple times a day that somebody needs to test, but your two statements of the FDA has approved CGM in place of self-monitoring, and then your statement of, well, yes, you do need to do self-monitoring during the 2-hour period. I mean, you can't make that comment, and I guess I don't think we should be making a decision here based on anecdotes of when people eat cake or something else. I'm not going to minimize the importance of these machines, but I also don't want to kind of have us sensationalized into kind of anecdotal evidence about when they should be used and when they shouldn't. So thank you. Appreciate your comment.
No, I would follow on that. I think the concern I would have is that we all know there are patients on both ends of the spectrum with diabetes management. There are some patients who are exceptionally attentive and responsible and don't mind the inconvenience and the discomfort that goes along with how much goes into repetitive finger sticks, and they're meticulous with management and have tight glucose control. And then we know what's on the other end of the spectrum, and all the family consequences of having somebody, particularly I have had some adolescent patients, you know, and I have their parents as patients, you know, when they go into a crisis, either, you know, on one end of the hypo or hyperglycemic crisis. And so I think my concern is, and why I asked about the lifestyle changes too, is that I see, you know, people want devices and they want things that will get them out of the burden of having to do all those things. And I think, to follow on Eric's point, if this device can get them to tighter control, but it doesn't substitute for all of that responsibility. And I think my concern would be, you know, how we present these options and how we set up the guidances in such a way that we don't encourage it as, you know, slap this device on and then you don't have to do anything else. And I'm impressed with how much is still required of the patient to do the self-monitoring along with the device. I think that was the first thing that struck me, because I don't do, you know, I'm not a primary care clinician, and I don't see these things in action. I was struck by how much is still required of the patient, even if they have one of these devices, to do the finger sticks along with it. And so I think we have to be careful as we're taking this all in, when we get to the point of writing up the guidances, that we're very clear with the wording and the language, so that we have all that specified in such a way that it's not leading to that impression in any way. So thanks for letting me say that.
Absolutely. Are we ready for the next public comment?
Yeah.
We've got, just going off the agenda here, Nicole Lynch from University of Utah Endocrinology and Metabolism.
Awesome. Can you hear me?
Yes, we can.
Awesome. I'm going to try and share my screen here. Are you probably able to see yourselves? Are you able to see the slides here? Hopefully. I'm going to just go. So I'm Nicole. I'm a nurse practitioner at the University of Utah, and I'd just like to start by introducing you to one of my patients. So Amanda. Amanda was diagnosed with type 1 diabetes in 2009. Initially, she was testing her blood sugars up to 7 times a day and was having success in terms of A1C, but still noted to have profound hypoglycemia. In 2013, Amanda had the birth of a son and has since struggled to test blood sugars more than 2 times per day. Her blood sugars were noted to be variable, ranging from 30s to over 400. Since 2015, she has had multiple episodes of DKA. In 2018, Amanda began experiencing hypoglycemia unawareness, not feeling hypoglycemia until in the 40s. Additionally, Amanda has struggled with life circumstances, has had food insecurity, poor family support, and difficulty maintaining supply of test strips. In 2019, the topic of CGM was brought up to Amanda. However, noting medication barrier suggestions have remained to check blood sugars more frequently. I started seeing her in January and ordered a CGM, but we're still working on getting approval. Since the beginning of the year, Amanda has gone into DKA twice, largely due to hypoglycemia fears. One of her DKA episodes has been while awaiting CGM approval. I would urge you to consider the barriers that Amanda and many like her face, and then ask yourself the things that we are waiting for to approve a CGM and at what point this would have been an inappropriate allocation of resources. Patients on Medicaid are often in a similar situation to Amanda. Their life circumstances are often littered with poor family support, poor health literacy, food insecurity, and even at times mental health difficulties. Often in order to qualify for a CGM, a patient must test their blood sugars 4 times per day for 60 days. It makes no sense that we would require a patient to test their blood sugars 4 times a day to qualify for a device where they do not have to calibrate at all. Patients who are non-compliant with testing blood sugars are often compliant with CGM therapy. The patients who are not checking the blood sugars at all are often the ones who need the CGM the most. I've literally had patients go into DKA up to 5 times in the amount of time it took to get these logs. Patients should also be able to get CGMs that will benefit them the most. So specifically, if the patient has a pump, they should be able to get a CGM that connects to it in order to best utilize closed loop pump technology. This includes both the Dexcom and Medtronic Guardian sensors. If they cannot get the sensors that match the pump, then the benefits of a CGM are far less effective. These devices are life-saving and they help prevent both hypoglycemia and DKA, but they are also life-changing, that people are able to have little peace and freedom with the devices otherwise not allowed to them. Please consider the approval for patients who are on intensive therapy, insulin therapy, both type 1 and type 2 diabetes. Treatment regimen is more important than diabetes type or education level when considering whether or not to place a patient on CGM. Lastly, something to note, I had them query the data at the Diabetes Center here at the University of Utah, and we have about 12.5 patients, including all insurance types that this would even apply to. So as previously stated, please approve this for patients who are giving short-acting insulin. Thank you for your time.
Thank you.
Nicole, thank you for your comments. This is Eric Cannon. One of the things we look at or looking at here is kind of criteria for use. And you see across the country, a lot of plans have criteria that limits the use of CGMs to type 1 diabetics. How many type 2 diabetics do you have that are on intensive insulin therapy?
So that's a good question. When I had them look at the data, I didn't have them split it into, so that 12.5%, I didn't have them split it into diabetes type, but I would say at least for my patients, it's probably around half and half, right, of that information, right? That 12% is half type 1, half type 2.
Okay. Yeah, no, thank you. That's helpful.
Any other questions?
This is Jennifer Brinton. Just one comment. I liked what Nicole said. I know about 20 years ago, I was at a pediatric conference talking about diabetes, and at that time they showed the preliminary data for continuous monitoring that then could connect to pumps and do delivery. And it was amazing to see the change in glucose control and the decrease in bad outcomes. And I was so excited 20 years ago to hopefully get this technology soon. So I like what she points out that mainly the if we are approving these devices, it would be very helpful to make sure that they do coordinate with the pump to really get the full benefit from what these devices can give. Thanks.
Thank you.
This is Joe with Medicaid. So, Ms. Lynch, to follow on to Dr. Cannon's question, patients that are type 2 with diabetes, what do you see as a profile of a patient that would be appropriate for CGM, a type 2 patient that is? Clearly, for example, a patient just starting on metformin may not be appropriate, or maybe it is. But anyway, I welcome your thoughts.
Yeah, so if they're on metformin only, right, that's not appropriate. It would be in the intensive insulin therapy. Often my type 2 patients who are on insulin therapy are on a large amount of insulin as well, just with insulin resistance. And so a lot of times that makes me worry almost more about having them drop just because they're on such high doses. Does that answer your question?
Hey, Joe.
Yeah, so for example, should we include, I'm sorry, Neil, but just a follow-up question. So should we include, for example, patients who are on the more concentrated U200, U300, U500? Should those be, should that be sort of hey, if you're on one of those, maybe we should consider CGM?
Absolutely, if you're on more concentrated, but I definitely think even if you're not on more concentrated insulin, right, the risks of low blood sugars are still there if you're on insulin therapy.
Thank you.
This is Roy from Dexcom. Just want to add to that. So intensive insulin, Medicare does cover for type 1 and type 2 on intensive insulin. ADA recommends intensive insulin. So 3 or more injections of insulin per day is the danger to the patient, not the type of diabetes. When you're a type 2 on 3 or more injections of insulin per day or insulin through a pump, you are just as dependent on your insulin as a type 1. And you're just as exposed to the risks of that insulin treatment regimen, which is hypoglycemia. And then as Nicole showed with Amanda, she just said, she swung all the way from hypo to DKA because of the fear of hypoglycemia and the risks of having a hypoglycemic event.
Thank you, Roy.
Okay, can we move on to our last public comment?
I think Neil had a comment or question.
Oh, go ahead. Sorry, Neil.
Let's go to the public comment, and then I'll jump in after that. I want to hear the next public comment, and then go in, and I'll save my comments for after public comment. Thank you.
Okay. Yep. Okay, we've got Jennifer Draney, Utah chapter of Insulin for All.
Hi, can you hear me?
Yes.
Awesome. Okay. So yes, so I'm Jennifer Draney. I work with the Utah chapter for Insulin for All and T1 International. I've been working closely with legislators this year to come up with a bill similar to Connecticut's on diabetic supplies. Last year, we worked on HB 207 for insulin. I'm working hard on diabetic supplies becoming affordable and accessible for all. I was diagnosed with type 1 diabetes at age 40, 2 years after my 16-year-old son was diagnosed with type 1 diabetes. Type 1 happens at any age. There's a stigma behind diabetes that we all need to learn more about, and it comes down to awareness. And that comes with type 2 diabetes as well. There's genetic comorbidities that come with type 2 diabetes that we don't yet understand. And I do believe pharmaceutical companies have something to do with that, putting pressure on treating the disease instead of curing it. So when you look at type 2s and whether they deserve to have a CGM or not, I hope you keep that in mind, that there's genetics behind a lot of this, and that type 1 happens at any age. So please don't restrict on age or types, just insulin-dependent diabetics that are in need. When my son was diagnosed, the doctor told us to set an alarm at 2 a.m. to go in and finger prick him every night because his was so severe. I believe they tell a lot of kids that. So parents get up and sneak in their kid's room, and you have to go hurry and prick them on the finger or on the toe to make sure they're not too low or too high. This disease is relentless. It's awful. This kid, he wanted to wrestle in high school so bad, and he couldn't do it until we got him a Dexcom. It took 1.5 years. I put in appeals with Medicaid over and over again to get one for him. Kept getting denied. We don't cover it. Kept getting denied. We don't cover it. Finally, he got one, and he got to wrestle his senior year, and he did great. He did so good, and he was at Bonneville High. And 1 year later, they denied his CGM with adult expansion Medicaid, just at his year renewal. The harder thing of saying you don't get one was to saying it was taken away. I can tell you that we've had these for years now, for years. And it's something that improves the quality of life. Your A1C improves your life as far as looking out for blindness, amputations, neuropathy, and death. To be able to go to bed at night and not think I'm going to die from a low in my sleep.
That's time. Thank you very much.
Thank
you. Any questions from the committee? Sorry, say that again.
I said, any questions, please? I'm a patient, so anything.
Yep.
So this is Joe from Medicaid. Thank you for your comments. Thank you for taking the time to come and visit with us. Just for clarity, so you're advocating for CGM for my notes are insulin-dependent patients?
Yeah, all insulin-dependent diabetics. And I don't believe you should have to fill out charts and stuff ahead of time and turn them in.
Thank you.
Any other questions?
Comments?
Any comments?
Absolutely. Okay, for full disclosure, I work for a diabetes company. We focus more on the insulin side. We do not have a CGM monitor or CGM at all. For full disclosure. And also, I am a person with diabetes that's worn CGM for probably 6 years now. And this is a tough conversation looking at the impact that diabetes has on people's lives. Insulin's insulin. Anytime we have a person on insulin, we do have that risk of hypoglycemia that plays in whether they're on multiple daily injections a day, which, yes, that does increase the chance of hypoglycemia. Also, when we get some of our type 2 patients that have had diabetes for a long period of time, they've been uncontrolled for a long period of time, we do run those risks of the hypoglycemia unawareness and things like that that really put people at risk for not just decreased quality of life, but increased chance of ED visits and things like that. CGM, it's a great tool. Back to Eric's comment, I don't know a person that has CGM or a patient I've worked with that did not have a blood glucose monitor that went with it. Yeah. You got to have them as a backup. Sometimes you forget to charge something or whatever, or there's a reading, things don't just match up. They go hand in hand to have there to get the most accurate evidence. Now, I'll be honest, do I use my blood glucose monitor? I'll find it and I'll get the dust off from it if I need it, but I don't. I rely on my CGM just from my experience and confidence in it. Back to the comment that came up on from Dr. Weinstein on lifestyle and things like that. CGM brings a whole new level of like food awareness and lifestyle awareness and things like that that come into living with diabetes. Things that I never saw with my monitor or never checked during the middle of the night or things I caught with CGM, and I was not just to fine-tune my blood sugars and things like that, I changed lifestyle. It helped me and my provider and educator go in the right direction to change lifestyle. So it is a powerful tool, and it really, it's become kind of standard of practice throughout diabetes. People not on insulin, straight on orals, unless there are people that are on sulfonylureas or at a risk of hypoglycemia, maybe a professional CGM would be in line for those groups. Or if they're on meds that do not cause hypoglycemia, self-monitoring seems to work great. But for people on insulin and really that are involved, engaged, and have an active support team, CGM brings great value to people living with diabetes.
Yeah.
I'll share.
Absolutely.
I could go on for hours, but thank you. Thank you for your time.
Thank you.
Thank you. Okay. Are we ready to take a look at the prior authorization criteria? And if you could remute your line if you're not speaking, we'd really appreciate that.
Okay, let's see here.
Hey, before we start going through this, can I just ask a quick question? And Joe or Jen, one of you may know. Can you explain to me this whole EPSDT kind of the early and periodic screening population? Because as I understand it, there are people within kind of traditional Medicaid where these devices wouldn't be covered. Am I correct in that? Or under your rules, are they covered for everybody?
Jen, you're welcome to take that, or I can if you.
I think she's speaking, but I haven't covered.
We're getting static on your line, Jen.
So Eric can answer your question while we wait for Jen to sort this out, because she knows more about it, and Brian can speak to this too. But EPSID patients can get CGM. They can get pumps too, but that goes through currently goes through a medical prioritization process. Our intent, I think, is to, but our intent is to move that over to the pharmacy benefit so that we can better manage this and provide CGM to patients who are in need of it, including adults, kids, whomever. Brian, is that fair?
Everybody.
The EPSID process is sort of an exception to policy. So the baseline is prior to now, these products have been not covered. But through the EPSID process, there was a path to coverage, if that makes sense. It's sort of an appeals process. And so the goal now is to open up coverage more broadly, to add these products to the preferred drug list, create prior authorization criteria, and open up coverage to those patients for whom it's appropriate.
And be transparent in that criteria.
Everybody in traditional Medicaid would qualify, but non-traditional Medicaid, are there populations that don't qualify?
Might be populations limited. We have reviewed on a case basis through the prior auth process.
All right.
We're still getting a lot of feedback from you, Jen.
People who are talking to mute their mics.
So Eric, I apologize. Did that answer your question?
Yeah, yes, no, it did. And I think kind of Brian's explanation of pathways being opened up. I mean, my understanding has always been that people were working on pathways to get these covered, but I was just kind of curious where that was. And I knew, you know, in the past, there have been some age brackets in different populations where they may not be covered. And so that's clarified everything for me. Thank you.
Okay, so we have our prior authorization request form on the screen here.
And just for the committee's benefit, Luis is a certified diabetes educator.
Great, thank you.
All right, thank you, everyone. So yeah, we're excited, definitely excited to present to you the Utah Medicaid CGM PA criteria for review. As we know that this technology has been shown to benefit certain patients with diabetes mellitus. And so, first, can everybody see the form? Okay.
Yep.
All right. So as you can see, it begins by defining the age criteria pertaining to each device, as you can see up there. And then after the age criteria, then we go into the criteria for approval. And first is diagnosis of diabetes mellitus. So we opened it up to type 1, type 2, gestational, and others. And that others is based on, you know, there's miscellaneous diabetes with etiologies like cystic fibrosis, medication-induced pancreatitis. So we just opened it up that way. And then also we have the providers attest to the patient or caregiver are complying with their diabetes treatments thus far, and that they are being supervised, and that they are capable of recognizing and responding to the alarms and alerts of the device. And second, they should also attest to the patient or caregiver having appropriate counseling and training for CGM use. And as you can see here, this PA criteria is designed to authorize a PA submitted for type 1 diabetes patients, as long as they meet the age limits for each device. The additional criteria for type 2 or gestational diabetes or other diabetes is the following. Patient requires basal and prandial insulin injections or Humulin RU500 insulin or insulin pump. And this is based on the guidelines criteria, medical guidelines stating, you know, intensive insulin. So we sort of define intensive insulin as someone using this regimen here, either basal prandial or Humulin RU500 or insulin pump. And in addition to that, the patient is performing blood glucose testing via finger sticks 4 or more times per day. Patient's insulin treatment regimen requires frequent adjustment on the basis of their BGM or CGM testing results. Or the patient has one of the following hypoglycemia conditions. Patient has hypoglycemia unawareness. Patient requires recurrent episodes, experiences recurrent episodes of severe hypoglycemia, defined as a glucose level of less than 50 milligrams per deciliter, which are not attributable to some type of dosing error, or there are other clinical rationale. Next is the criteria for replacing the receiver is, you know, as listed here, the current device is deemed inoperable or ineffective due to damage from events outside the control of the patient. The patient is compliant with the device and the device is required and continues to provide benefit to the patient's diabetic regimen. Replacement cannot be obtained through the supplier or manufacturer as if the warranty is expired. The replacement device is similar to the current device without additional features and enhancements. In terms of the non-preferred criteria, we require trial and failure of the preferred CGM for the Utah Medicaid PDL, or prescriber must demonstrate medical necessity for a non-preferred product. Reauthorization criteria, we require that the doctor submits documentation indicating the device is required and continues to provide benefit to the patient's diabetic regimen. And also documentation of a face-to-face visit with a provider in the last 6 months, because we feel that having that face-to-face interaction is necessary for the patient to feel comfortable, asking any questions about operation of the device and things like that. Initial authorization, sorry, is set up for up to 6 months, reauthorization up to 1 year. And down here, we have the product that will be added to the PDL as preferred, which is Dexcom G6. All right, any questions?
Yeah, Louis, this is Eric. Hey, can you scroll back up? I mean, I got a couple questions on a few of these sections. So if you go back to type 1 category, patient and or caregiver complies with a comprehensive diabetes treatment plan supervised by the treating provider and is capable of recognizing and responding to alarms and alerts. One of the things that I guess we've looked at in terms of this is the patient currently doing the self-monitoring? And I understand maybe brittle type 1, they're not gonna test times a day or something, but is there a limit of testing that should be happening already to demonstrate their willingness to really follow through and follow this? And part of where I'm going with it is, in the past, I had an individual working for me, had a continuous glucose monitor. He sat outside my office, and there were days, and it took me about a month to figure it out, but there were days that I would just hear this alarm going off continually. And the reality was, yeah, he was on a CGM, but the monitor was sitting at his desk and had gone off somewhere else for 8 hours. And so, this only works if there is truly a commitment. And so I guess what is that commitment beyond just the physician saying, yeah, they're capable of doing this? I mean, that's one concern I have, is just, and maybe I'm taking it too far, and Neil, I'd love to hear just kind of your perspective from kind of where you work and what you do. But the other is, I don't know that somebody using basal insulin once a day qualifies as intensive insulin, at least in a type 2 diabetic. So if it does qualify as intensive insulin therapy, then that's fine. But I guess I'm having a hard time figuring out, because I mean, we use basal insulin in type 2s because it does tend to not have the hypoglycemic effects and be easier to manage and monitor. So I guess I'm questioning that. And then this notion of hypoglycemia unawareness, I quite honestly, up until we started having these conversations, was unaware what hypoglycemia unawareness is. And so I think there's a lot of physicians that will just automatically check, oh yes, they have hypoglycemia unawareness. And does that need to be broken down more into a definition of something that is indicating their unawareness has caused at least one visit to an emergency room? Their unawareness has caused some kind of hospitalization, or there's documentation that notates kind of frequent and significant hypoglycemic events that may not have required going to the ER or something else. But just saying hypoglycemia unawareness, I think there's a lot of physicians that will just check the box and maybe even go back and write in the chart, patient has hypoglycemia unawareness, without really taking it to the next step about, definition of that and what does it really mean? So those are my questions or thoughts or comments, and I'll stop there.
Yeah, thank you, Eric. So regarding the comment that you made about type 2 patients just on basal insulin, right? So if you look at the first bullet up there under additional criteria for type 2 or gestational or other diabetes, that's really defining intensive insulin for us, which is basal and prandial insulin injections, right? Or Humulin RU500 insulin, which that one has components that work prandially and like as the basal and prandial coverage, right? That's how RU500 works. Or
yeah, that makes sense. My ADD neglected to see the "and" statement there, so
okay.
Forgive me for that.
No problem. No problem. And in terms of the comment that you made about hypoglycemia unawareness, you know, that usually happens with people who have more advanced disease. But I think you're right in terms of maybe adding something in there, like such as hypoglycemia unawareness leading to blah, 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 to kind of have the doctor attest to, yeah, it is a problem for this person. They do have it.
Eric, these are all great questions and comments. Now, I'm just trying to think through, and on the hypoglycemia unawareness, people living with diabetes, hypoglycemia, and if hypoglycemia is present and reoccurrent, everybody's pretty aware of it. All family members, the provider, everything. Many times it's impacting work, it's impacting ED visits, all these things go along with it. The part with the CGM, it's interesting. I go back and forth on this because I see the value of just poking your finger and testing your blood sugar, but in reality, many people living with diabetes, they'll start doing that, they're engaged. And I'll be honest, also with CGM, you'll see this too. People are engaged, they're actively participating, and then they kind of fall off the wagon. The thing, if you've got a person that's testing multiple times a day, the chances of them doing it, especially if they're out and about or in a business meeting, they're working and stuff, the chances of testing go down with finger stick. With CGM, being able to look at a monitor or scan and make a decision based on, at lunchtime, I'm going to take this bolus with my reading. Other times I may skip that bolus because I didn't want to get up and go to the bathroom to test my sugar. It was inappropriate at the table, or whatever barrier was there. The CGM makes a tremendous difference in those areas, not just centered around, the hypos, but again, being part of a person that's living with diabetes, part of the impact on their life, and getting them the care, and ultimately down the line, decreasing those complications that show up with uncontrolled diabetes way down the line. They're coming. Any way we can slow them down and stop them, prevent them with tools and devices. I get SMPG was fabulous, but with CGM, and again, I struggle with both prandial insulin there. I understand with guidelines, but with people on insulin therapy, and goals now, you'll see a lot of people that are never going to a basal bolus. They're type 2s. They're not going to a basal bolus regimen because they're on an SGLT2 or a GLP-1. They're doing fine. But again, this could be a tool that could prevent, help them achieve better outcomes, better goals, and decrease the chance of complications down the line. In my eyes, it's just a more powerful tool for people to control their blood sugar, stay out of harm, and also take burden off family members. These devices, especially with the alarms or tools where other family members can see what's going on, and this is mainly in type 1s or people prone to hypos or parents or caregivers, elderly caregivers, where you can see a family member's sugar reading and see what's going on and maybe prevent them from having that severe low or ending up in the ED. There's so many other things that go around with this tool that really bring value to people with diabetes, keep them out of harm, and hopefully prevent the bad outcomes.
Yeah, and I guess my only concern is, should there be some commitment demonstrated by the patient up front before we as a state enter into the expense of this type of monitoring system? You have to be committed to this, even though it continually monitors your glucose. If you're not committed to your disease, this will do nothing for you. And so I think there's very good evidence supporting the use of CGMs in a much broader population, maybe than what we've even allowed to date. But
I think that's what we're trying to get at with the second and third bullets up at the top, is that the patient and caregiver are compliant with a comprehensive treatment plan, and the provider attests that they provided that training. And I mean, beyond that, it becomes a big hurdle if we require extensive documentation of that. And so that's kind of what we're trying to address with those criteria.
Yeah, and I get what you're saying, but I think there has to be something objective about it, not just patient and caregiver complies with comprehensive diabetes treatment plan. I worry that sometimes a lot of patients don't have a comprehensive treatment plan, yet physicians would say, oh yeah, they do. Or, yeah, I had tests, that they've had appropriate counseling and training. Appropriate counseling and training is one thing. A commitment to follow through on appropriate counseling and training is another. And there needs to be some objective measure of that. And I think in the past it's been, how frequently are you testing today? And can you prove that?
Eric, to be fair, we're not requiring that of the other disease states that we approve drug therapy for. I don't think we need to set the bar higher for treating diabetes than we do for anything else. I feel like what we have on this form is more than adequate, and anything more than that would be stepping into the relationship between the patient and their prescriber, which is not something that we do.
And the CGM gives the patient and the provider a chance to have data to make decisions where they did not have this before. Even if they test 10 times, 20 times with finger sticks, it's not enough to make good decisions to have a good diabetes treatment plan and for the patient or the provider. The CGM is that source of truth on, is the patient eating right, using their insulin correctly, and pursuing a good lifestyle with regards to exercise or whatnot. So the data is needed for the patient to be successful and to keep them safe with the alert or alarm, and especially at night.
Okay, so what I would suggest, and Catherine, I don't disagree with you. I've seen enough over my career where I've seen us make significant financial investments in people just to have them not follow through with any of it. And so I'm totally okay with the criteria as it stands here, as presented. But I would absolutely want to see data back in 6 months showing us how many people got set up on a CGM and how many people have continued over time to refill the supplies and get everything else that goes along with it. Because, I'd make an argument that even if we see 25–30% of people not continuing to get the supplies, then we do need to come back and revisit this criteria, because we have a portion of the population that's demonstrating that we're making a commitment to them. They're not making a commitment to themselves and everybody else.
And Eric, I think we're already seeing this with test strips, because you'll see this a lot of times. People will fill their test strips great for a while, and then again, they won't fill them. Again, different things in life, the life of diabetes getting in the way. But with the CGM, we're giving the time the patient's using it and that interaction with the provider, we're given so much more usable data to use and make true decisions that really improve people's lives more so than those test strips. And, you know, if you've got an engaged person that will test their blood sugar, write it down or upload it or get it to the provider and then meet with that educator and go through the results, make changes, great. But the chance of that happening is so much better with the CGM and it's just, there's more usable data. And I think in the long run, the bang, I'm hypothesizing here, but you know, in the long run, we're going to see better data, better outcomes, and better, you know, long-term outcomes by the use of CGM over test strips.
Yeah, and I guess my biggest issue here with all of this, and then I'm going to shut up and just crawl under my desk or something, but I'm very concerned about the marketing of these products, which basically is slap a CGM on and you will suddenly be able to do all kinds of amazing things to control your diabetes. Data without a commitment to use the data and data without a commitment to take action and communicate with your provider is just that. It's just a stack of data. And so, you know, we need to be careful in saying this is the end all be all to all of this, because ultimately the patient's willingness to manage their disease still overrules everything else that we may be doing. And so and how we motivate patients, I think we've been talking about that for the last century, but you know, how do we get patients to do the right things? But let's be clear that this data without action by the patients and a willingness to monitor and actively manage their disease doesn't really change the picture of things. So, you know, and I think there's good data to support it being that people are getting better outcomes with these, but there's also a lot of people that are getting them. We are spending a lot of money and we're in the same place. It's just like where we were with self-monitoring. And I can show you patients that, you know, we bought 200 test strips a month for the last 4 years, and they're still at an A1C of 9 or 10. And if we went to their house, we'd probably see a closet full of test strips. So, I mean,
just one thing about that.
That's the one. I'm sorry, that's not going to change with the device, except maybe for some patients whose care is facilitated by the use of the device, and that's partly why I was asking about what data do we have about lifestyle change. I have a suggested wording change on that top paragraph. We're not using the word comply so much anymore, right? So I think we're using treatment adherence, or we could say patient and or caregiver are engaged with their diabetes treatment, or fully engaged, or they're adherent with. I mean, this I think speaks to, you know, Eric's point also to say that we've got some documentation. I appreciate the concern about the financial investment, but I think what we're really trying to get at here is selecting the patients and not putting a barrier in for those patients who are going to be able to use this most effectively. And then on the back end, can we see, I don't know if it's 3 months or 6 months, but, you know, what would we do? Would we collect the devices back from those patients who aren't using them? Probably not, right? So I think it would be important to see, you know, what are the positive outcomes in terms of cost avoidance and all those sorts of things. That's not our focus in this committee, but I do think we want to know: is it a clinical judgment? Is it some stability of their management to the point where now this is going to be a very important tool to improve their clinical outcome and quality of life, and both of those things can be tracked. But again, we're not putting that kind of documentation on other sorts of disease states. So I share the concerns, but I don't know how much more we can put into this.
Can I move this along just by saying I move to approve the criteria as presented and amend that slightly to say that along with approving the criteria, we will review utilization data in 6 months.
But
Do
before
you
that,
also want to change the wording from compliance to adherence?
Yeah.
Yeah.
and can we change that first line to, instead of basal and prandial, to insulin?
The reason why we require basal and prandial is because of the guidelines recommend intensive insulin, right? So intensive implies that the patient is both on some kind of basal and prandial component type insulin regimen.
I was looking at that. I was thinking, maybe I'm wordsmithing here, but for people with type 2 diabetes, such as those on intensive insulin regimens and in those on regimens associated with hypoglycemia. And again, I go back to the point that, I feel that these CGMs are not going to be just prescribed by everybody, that they're going to be utilized by people who are familiar with them. They have the infrastructure in place to do the training and have that infrastructure for ongoing follow-up. These are tools for people actively engaged in their diabetes care, same with their providers and their teams. And that's where, I'm just stuck on that line, and those on regimens associated with hypoglycemia, and that just pulls in insulin straight across the board. So I hate to just you've got a motivated type 2 out there that's on basal insulin, that's making progress, and this is a tool to help them with their food awareness and things. Maybe I'm reaching here. Maybe we start here and then look at that down the line. But I just wanted to share and get thoughts with the committee before we move on.
Perhaps you could use the wording from page 25, where they talk about non-intensive insulin regimens in the context of hypoglycemic unawareness, recurrent hypoglycemia, or severe hypoglycemia, and use that wording instead to speak to Neil's point.
I think that'd be okay.
Or perhaps leaving it how it is, and then with this bullet point right here, other reasons for CGM with clinical rationale, and consider those on basal insulin type 2s, on a case-by-case basis for now.
Yep.
Okay.
Now we're starting to lose board members here because we're past time.
And I think Kumar has a comment.
Yeah, the comment I have is, should we not be requiring recertification as far as training and counseling is concerned? I think that is very important, because if we are going with 3 months, 6 months, right, that they come back, then I think it behooves me that we are not asking for recertification, because you can give me training today, and if I'm ignoring what you taught me, then it's of no value.
Well, hopefully the team's addressing that when the patient comes in for their A1C, and when they're downloading or reviewing the CGM data. Hopefully that's being addressed, or if they're not making progress.
I think that's covered on appropriate counseling and training, wouldn't you think? On that bottom line, on the first set.
Provider attests to the patient and our caregiver having appropriate counseling and training for CGM use.
So you see, every time I give you a new prescription, that ought to be one of the criteria that we make sure that counseling and training is absolutely appropriate. That's what I think.
Okay.
So
I
bullet,
think it's here with that line 3.
bullet number 3 would require some changes. That's what I'm getting at.
You could, I guess, with continued reinforcement or
That could
continue with continued
You could say
evaluation.
you could say ongoing counseling and training
Yeah, yeah,
rather than appropriate.
yeah. Okay.
Yeah, that'll work. Thank you.
Okay, can we get a motion? Is that possible?
I think Eric has one. Do you want to continue with your motion, Eric?
Yes, I absolutely do, because everybody thinks I'm going to kill patients and deny access to these devices.
We know better than that. We know better.
And I'm
We
going
don't.
to clarify this for everybody out there in the public. I have family members that are type 1 diabetics. I watched an aunt lose her legs to type 1 diabetes. I understand the severity of this disease. I am adamantly opposed to the notion that a CGM will simply, by putting it in the hands of a patient, completely change the way they manage their disease. I think it provides excellent data for the management of a disease, but there has to be a commitment to manage the disease beyond just slapping on a CGM. So yes, I move to approve this criteria with the amended changes that we've discussed.
I'll second
Can I
that.
get thank you, Neil. Any further discussion? Okay, all in favor of approving the criteria with the amended changes, say aye.
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 Any opposed? Any abstentions? All right, we have approved criteria. Thank you so much. This was a great discussion. Anything else we need to entertain before we adjourn? Great. Is there a motion to adjourn?
Move to adjourn. Kumar's got the second.
Excellent.
Love you, Eric.
Love you, Eric. Have a great week.
God bless.
We are adjourned.
And thank you to all the patients for sharing.
Yes, thank you.
Absolutely.
Appreciate it. Have a good one, everybody.
Bye-bye, everyone. Thank you.